Okay, so you've sent over some really fascinating material. It digs pretty deep into how our brains and sometimes our personalities can face some, well, serious challenges.
Yeah, we're looking at information covering both neurocognitive disorders and personality disorders.
And it can feel like trying to navigate a maze sometimes, can it? Trying to sort out what's what.
It absolutely
Yeah.
can. And that's really why getting a handle on the fundamental differences is so crucial. We're looking at two, quite distinct categories of challenges here.
Exactly. So our mission, I guess, for this deep dive is to really get under the hood. Explore those core distinctions between neurocognitive disorders, things like delirium and that whole spectrum of major and mild neurocognitive disorders,
Right.
and then personality disorders. We want to help everyone listening get a really solid grasp on what sets them apart.
And maybe touch on some key features without drowning in, all the technical jargon.
Perfect. Okay, so let's kick off with neurocognitive disorders. What's the absolute, core thing we need to understand about them?
The crucial takeaway, really, is that these disorders involve a change, a deficit, technically, in someone's cognitive functioning, how they think. Remember, process things.
A change from how they were before.
Exactly. A decline from a previous level. And often, we can actually pinpoint an underlying cause for that shift.
Okay.
And the source material helpfully breaks down the abilities affected into 6 main areas or domains.
Oh, right. What are those again?
There's complex attention, like focusing on multiple things, then executive function planning, problem solving, that sort of thing.
Uh-huh.
Learning and memory, obviously crucial. Language skills, perceptual motor abilities, coordinating senses and movement.
Yeah.
And finally, social cognition, how we understand social cues and interactions.
So it's really about a shift in how the brain is currently working.
Precisely. It's not necessarily about who someone has always been, fundamentally speaking.
That distinction feels really important already. Okay, so the first specific type mentioned is delirium. What's the quick summary on that one?
Think sudden. Delirium is basically a state of confusion and altered awareness that develops pretty fast.
How fast?
We're talking hours to maybe a couple of days. And its intensity isn't stable. It can fluctuate quite a bit.
Fluctuate, throughout the day?
Yeah, often getting worse in the evening or at night. And it's not just confusion. There has to be at least one other cognitive issue going on.
Such as?
Problems with memory, maybe disorientation, not knowing where they are or what time it is, or issues with language.
Got it. Comes on fast, fluctuates, and affects more than just awareness. What usually triggers it, or who's most at risk?
Several things. First, it's important this isn't just part of another neurocognitive disorder or happening during a coma. There's typically a direct physical cause.
Like a medical issue.
Exactly. A medical illness, maybe substance intoxication or withdrawal or exposure to a toxin. The source actually flags 5 groups that WISE identified back in '95 as high risk.
Ah, who are they?
Older adults are one key group. Also, people with what's termed decreased cerebral reserve, basically. Less brain resilience, maybe from a past stroke or early dementia.
Okay, makes sense.
Then post-cardiotomy patients after heart surgery, burn patients, and people going through withdrawal from substances.
Wow, okay. Those are all pretty intense physiological stressors.
They really are. And the source also lists more general conditions, infections, metabolic problems, electrolyte imbalances, even just recovering from surgery or a head injury can trigger it.
And you mentioned older adults, but are there others particularly susceptible?
Yes, besides older adults, very young children are also noted as being at increased risk.
So when someone is experiencing delirium, what's the main focus for treatment or management?
Top priorities. Find and treat the underlying cause, that's number 1, and then manage the agitation and distress,
How do you manage the agitation?
often through environmental changes, making the surroundings calm, familiar, maybe reducing stimulation. Psychosocial support is huge too, like having a family member present offering reassurance.
And medication.
Sometimes, yeah. If agitation is severe or there are hallucinations, a medication like haloperidol might be considered. But the focus is really on fixing the root cause and supportive care.
Okay, so that's delirium, acute, fluctuating, usually has an identifiable cause we need to fix. Now, let's broaden out to major and mild neurocognitive disorders. What's the core difference there?
It really boils down to severity and impact on independence.
Okay.
Major neurocognitive disorder means the cognitive decline is significant enough that it actually interferes with the person's ability to live independently, to manage their daily activities.
Right, like paying bills, managing medications, that kind of thing.
Exactly. Whereas mild neurocognitive disorder involves a decline that's noticeable more than just normal aging, but it doesn't take away their independence.
So they can still manage, but maybe it takes more work.
Precisely. They might need to use compensatory strategies, put in more effort, or need a bit more time, but they can still function independently day to day.
Okay, so it's really about that threshold of impacting independence. And I gather these terms replace some older ones.
They did. Major neurocognitive disorder largely covers what used to be called dementia, and mild neurocognitive disorder is similar to the older category of cognitive disorder, not otherwise specified, or NS.
Right.
And what's interesting now with the DSM-5 system is that it identifies 13 different types of these disorders, both major and mild.
13, based on the cause.
Exactly, based on the specific underlying etiology or condition that's believed to be causing the cognitive decline.
Okay, 13 is a lot to cover. Let's maybe focus on the big one. Neurocognitive disorder due to Alzheimer's disease. What are the diagnostic signposts for that?
Right. So first, the person has to meet the general criteria for either major or mild neurocognitive disorder. Then, crucially, the onset has to be insidious, gradual, and the progression steadily downward over time.
Not sudden, like delirium or maybe a stroke.
No, it's a slow, gradual worsening. For a mild diagnosis, the impairment needs to affect at least one cognitive domain. For major, it's impairment in at least two domains.
Okay. And then there's probable versus possible Alzheimer's.
Yes, probable. Alzheimer's usually means there's evidence from genetic testing or a clear decline in memory, plus at least one other cognitive area, a steady progression, and no signs that something else could be the cause.
And possible.
Possible is diagnosed if maybe the genetic link isn't there or the pattern of decline isn't quite as classic, perhaps suggesting another condition might also be contributing.
It sounds like actually confirming Alzheimer's while someone is alive is tricky.
It is very tricky. The source really emphasizes that a definitive diagnosis, the gold standard, usually requires examining brain tissue after death.
An autopsy or biopsy?
Right. To actually see the characteristic neuron loss, the amyloid plaques, those protein clumps, and the neurofibrillary tangles, which are like tangled fibers inside the neurons in the specific brain areas affected by Alzheimer's.
And just how common is Alzheimer's?
It's the big one. The most common cause of dementia, hands down. The source quotes figures like 60% up to even over 90% of all dementia cases.
Wow.
And late onset, the type appearing typically in someone's late 70s or 80s, is much, much more common than the early onset form.
And people often talk about Alzheimer's progressing in stages. What does that typically look like?
The source lays out three general stages. Stage 1, maybe lasting 1 to 3 years, is often marked by what's called anterograde amnesia.
Trouble forming new memories.
Exactly. Difficulty remembering recent events, new names, conversations. You might also see visual spatial problems judging distances, navigating which can lead to wandering, and maybe some changes in mood or personality like indifference, irritability, or sadness, and anomia, trouble finding the right words.
Okay, that's the early stage. What about stage 2?
Stage 2 can last quite a bit longer, maybe 2 to 10 years. Here, you often see increasing retrograde amnesia, difficulty recalling past events.
So losing older memories, too.
Yes. Mood changes can become more pronounced. Restlessness, agitation are common. Sometimes delusions, false beliefs can emerge.
What about language and movement?
Language often deteriorates into what's called fluenaphasia. They might speak easily, but the content doesn't make much sense. Acaculia, difficulty with math, is common, and ideomotor apraxia.
What's that last one?
It's difficulty performing familiar, purposeful actions on command, even though they understand and are physically capable. Like they know what a key is for, but struggle to mime turning it in a lock if asked.
That sounds incredibly frustrating for the person. And stage 3?
Stage 3, maybe 8 to 12 years into the illness, involves really severe intellectual decline. Apathy is often prominent. Physically, there can be limb rigidity, stiffness, and typically loss of bladder and bowel control.
It's a devastating progression. What do we know about the underlying causes? You mentioned genetics earlier.
Yeah, genetics definitely play a role. Certain gene abnormalities on chromosomes 1, 14, and 21 are strongly linked to the rarer early onset familial form.
And for the more common late onset?
The ApoE4 gene variant on chromosome 19 is a major risk factor. It doesn't guarantee someone will get Alzheimer's, but it significantly increases the odds.
And beyond genetics?
Neurotransmitters are involved, especially acetylcholine, which is vital for memory. Levels are often reduced. Other factors linked to increased risk include lower education levels, adult-onset diabetes, depression, a history of traumatic brain injury, and having Down syndrome.
So it seems like a mix of genetics and other health and environmental factors. What about managing the condition? What approaches are used?
It's usually a combination approach.
Hmm.
Things like group therapy, focusing on reality orientation, keeping track of time, place, person, and reminiscence therapy can be helpful for some.
Managing behaviors.
Right. Behavioral techniques are key for managing things like agitation or wandering. Sometimes antipsychotic medications are used for severe agitation or aggression, but cautiously. Antidepressants might be needed for depression.
And environmental tweaks.
Absolutely.
Yeah.
Simplifying the environment, making it safe and familiar, reducing confusing stimuli. And then there's pharmacotherapy aimed at cognition.
Those are the memory drugs, like Aricept.
Exactly. Cholinesterase inhibitors like Dumpezel, Aricept, ribostigmine, galantamine, Tecrine was an older one, they boost acetylcholine levels.
Do they work well?
They can offer some benefit, particularly in mild to moderate stages, helping with cognitive symptoms and sometimes behavior, but, and this is important, they don't cure the disease or stop its progression.
So temporary improvements, maybe?
Yeah, the improvements are usually modest and temporary. The source also makes a really interesting point about outcomes,
Which is?
that patients often do better, have better outcomes when they can remain at home with good family support.
That makes a lot of sense. That familiarity and connection must be huge. Okay, let's quickly touch on vascular neurocognitive disorder. What defines that?
This one's diagnosed when the cognitive decline meets the criteria for major or mild NCD, and the clinical picture points strongly towards a vascular cause problems with blood flow in the brain.
So evidence of strokes or something similar.
Exactly. There needs to be evidence of cerebrovascular disease, maybe from a neurological exam, patient history, or brain scans that seem sufficient to explain the cognitive problems.
And how does this one tend to progress? Is it different from Alzheimer's?
It can be quite different, yeah. Sometimes it's an abrupt onset after a major stroke, maybe with some recovery. Other times it's a stepwise decline,
Stepwise.
meaning periods of stability followed by sudden drops in function after smaller vascular events. Or it can be a gradual progression, but often with more noticeable fluctuations or plateaus compared to the steadier decline in typical Alzheimer's.
And the risk factors are probably what we'd expect for vascular issues.
Pretty much. High blood pressure, diabetes, smoking, obesity, high cholesterol, atrial fibrillation, all the usual suspects for heart and blood vessel health.
Got it. And the last specific NCD mentioned was due to HIV infection. What are the key features there?
This type often impacts the subcortical brain regions more. So common symptoms are things like impaired concentration, trouble learning new information, slowed thinking, and movement psychomotor slowing. Also apathy, depression, and sometimes motor symptoms like tremors, clumsiness, or abnormal eye movements.
And there's a more severe form associated with AIDS.
Yes, the source mentions AIDS dementia complex, or ADC, which represents a more advanced stage of neurocognitive impairment linked to HIV.
Does ADC have stages too?
It does. The material outlines 6 stages, from stage 0 normal up to stage 4 end stage. These stages reflect progressively worse cognitive, functional, and motor impairments as the condition advances.
Okay, so wrapping on the neurocognitive side, the big picture is a decline in thinking abilities, often with known causes affecting how the brain functions day to day.
That's a great summary.
Now let's completely switch gears. Personality disorders. What's the fundamental contrast here compared to neurocognitive disorders?
Well, the name itself gives a clue, right? Personality disorders are about enduring ingrained patterns of inner experience, thoughts, feelings, and behavior that are really different from cultural expectations.
Enduring meaning long-standing.
Exactly. Pervasive, inflexible, and long-standing. The source lists quite a few. Paranoid, schizoid, schizotypal, antisocial, borderline, and it specifically mentions DBT, dialectical behavior therapy, as a key treatment for borderline,
Right.
histrionic, narcissistic, avoidant, dependent, and obsessive-compulsive personality disorder.
That's a diverse list, but the core difference isn't about a loss of cognitive function, is it?
No, that's the crucial distinction. Neurocognitive disorders generally involve identifiable brain pathology and a decline from a previous level of cognitive functioning. Personality disorders aren't primarily defined by cognitive decline,
So what are they defined by?
by these deeply ingrained, inflexible, and maladaptive patterns of thinking, feeling, behaving, and crucially, relating to others. These patterns usually emerge by adolescence or early adulthood and persist over time.
So neurocognitive affects thinking and memory primarily, while personality disorders shape how someone fundamentally interacts with the world and themselves.
That's a really good way to put it. One impacts cognitive abilities, often due to a disease process. The other describes long-term patterns of being and relating.
It's like neurocognitive is maybe a change in the brain's hardware function, while personality disorders are more about the long-standing operating system or software, how the person processes and interacts.
That's actually a pretty helpful analogy, yeah. A decline in function versus an enduring pattern of relating.
Right. Okay, so just to really nail down that distinction for everyone listening, neurocognitive disorders mean a decline in cognitive skills someone used to have, usually linked to something specific affecting the brain.
Correct, like Alzheimer's, stroke, HIV, etc.
Whereas personality disorders are these long-term, stable, pervasive patterns of inner experience and outward behavior that shape how a person sees and interacts with the world.
Precisely. They emerge earlier in life and are more about relational styles and ways of interpreting the world.
And while the sources didn't dive into this much, I guess it's possible for someone to experience both. Life isn't always neat categories.
Absolutely, that's a very important point. Comorbidity, having both, is certainly possible. Clinical presentations can be complex. These distinctions are helpful, but reality can be messy.
Definitely something to keep in mind. Well, this has been incredibly helpful in clarifying what can be really confusing territory.
Oh, we could walk through it.
So, thinking about these fundamental differences, changes in thinking versus these enduring personality patterns, it does raise some interesting questions, doesn't it?
Like what?
Like, what are the implications for how we understand these challenges, how we offer support, and maybe even how society perceives them differently? Is a condition affecting thinking viewed differently than one affecting personality?
That's a really powerful thought to leave people with. How do those labels and underlying differences shape everything from treatment approaches to stigma?
Exactly. Definitely something worth reflecting on, maybe as you look back over the source material with these distinctions clearer in mind. Thanks so much for unpacking all of this today.
My pleasure. It was a great discussion.